sponsored by Heathrow. Heathrow Healthcare Doctors, as you know, has got 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio with presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have got Asia's largest manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide range of products encompassing multiple specialties. Pioneering in quality and innovation, Heathrow Healthcare has distinction of bringing 4 biosimilar products to market within 5 years of launch.
Yeah.
Today's webinar, Carbetocin in action. As you all will agree with me, carbetocin is a drug which is used for prophylaxis of PPH. PPH is a condition which potentially can be disastrous. Although there are many studies and documents on use of carbetocin in PPH, we always like to get experience from our own doctors, our own experts, to share their experience and their view about carbetocin. Today we have got Dr. Anju Sharma with us. Welcome, madam. Dr. Anju Sharma is, yes, Dr. Anju Sharma is MBBS, MS and senior resident at SN Medical College, Agra, with fellowship in reproductive medicine. Madam is senior consultant obstetric gynecology, director Lotus Super Speciality Hospital, Agra, and consultant at Maitri IVF Center, Agra. The area of interest include critical obstetric care and infertility, with future goals promoting teen approach. Welcome, madam. And
thank you,
welcome.
Prashantji.
Yes, and over to you for the presentation.
Yeah, very good evening. And today's topic is very important. It is review on postpartum hemorrhage about a new drug, Carbetocin. So it is a very, very important topic. We can reduce maternal mortality and morbidity to a very large extent if we are properly using third stage labor management. So this is a new drug. I think you can switch a new slide. So, postpartum hemorrhage can be defined as any amount of blood loss in normal delivery more than 500 ml and during cesarean section more than 1000 ml. But little bit change is there. Any amount of blood loss in a pregnant woman that can alter her hemodynamic stability. Her pulse rate is increases, her blood pressure is falling. Even about 300 ml of blood loss can be called as PPH, according to the status of the parturient lady. So if we are going to the incidence of PPH, the maternal mortality rate in developing country is 240 per lakh live birth. It is very high. While in the total global maternal mortality rate is 14 million women suffers from PPH, and incidence is reported to 2 to 4% in normal delivery and more than 6% in cesarean section. If we go to the incidence in India, it is somewhat higher. 38% women suffers from PPH, and it is 25.7% of global PPH load. So in India, it is very, very high, and it is a major cause of maternal mortality, that is up to 550 per live birth. Next, if we go for the causes of postpartum hemorrhage, so it is a very mnemonic to learn it and to manage also. First, 4 T's. First T is tone. Atonicity of the uterus is very important cause of PPH, and it accounts for 80% causes of PPH. Second is trauma. Like any trauma in the genital tracts, right from the cervical tear, vaginal tear, uterine rupture, or inversion, or any kind of difficult delivery can lead to PPH. It accounts around 19 to 20%. And rest causes, that is tissue, means retained placenta or retained clots inside the uterus. And fourth is the thrombin, that is a little bit rare. Coagulopathy is there, some coagulation factor defect is there. So we can find out the etiology of the postpartum hemorrhage, and it is very, very must for a gyneco-obstetrician to manage the PPH and to find out the cause also simultaneously. And investigation, all the three things should run in a same go to save the life of a woman. So quickness of a gynecologist is very, very important in these cases. Next. So clinical, if we go for the clinical finding, so It depends on the amount of blood loss. There will be abdominal tenderness, circulatory collapse, increasing abdominal girth if it is a atonic PPH. In atonic PPH, uterus fails to contract and blood start collecting inside the uterus, and there will be increasing abdominal girth. And there will be loss of uterine contraction, maternal tachycardia will be there, and obvious vaginal bleeding will be there. So if we go according to the blood loss, if it is around 500 to 1 liter, 500 ml to 1 liter, that is 10 to 15% of the blood volume, the lady will not be much affected. There will be only palpitation and dizziness and tachycardia if her hemoglobin previously was normal, above 11. And if the blood loss is more than 1 liter to 1.5 ml, that is 25% of the blood volume is lost. There will be slight fall in the blood pressure, and there will be weakness, sweating, and tachycardia. If it is moderate, that means 1.5 to 2 liter, 35% of the blood volume. There will be marked fall in the maternal blood pressure, and restlessness, pallor, oliguria will be there. And if it is more than 2 liter to 3 liter, that is up to 45% of blood is lost, that it will be very grave condition, very serious condition. That means profound fall in the blood pressure, and collapse will be there, air hunger or anuria. Next. So it is very important for a treating doctor to rapid do the assessment of the patient if there is tachycardia, hypertension, or what are the vital signs. So assessment of the entire genital tract. First, we will keep a hand on the abdomen. If the uterus is contracted, then we'll look for traumatic PPH, manually retained placenta if there are any side of, if we have ultrasound available, it is very good. Keep the ultrasound probe of the abdomen. If there is if there is a retained placenta or clot, remove first. Okay. And look for the uterus for any uterine inversion. And simultaneously, we should send blood for the complete cross CBC and hematocrit and platelet and coagulation studies, and blood for cross matching and blood donation, blood arrangement, blood products arrangements. Next. So again, it is the according to the cause, how to manage a patient. If it is a poor uterine atony, uterine tone is lost, it is a atonic PPH, then it is called atonic PPH. It is the most common cause. It can occur in any lady without any predisposing factor. So abdominal palpation is the very important part. Uterus will be soft, relaxed, bogy, and there will be no tone inside the uterus, and the fundal height will keep on increasing. In this situation, we will simultaneously send the blood for CBC, coagulation profile, and urea and electrolyte. If the patient is not responsive, then we should fast transfuse the first crystalloid and do the abdominal sonography, and uterotonic simultaneously given in the form of oxytocins, prostaglandin, ergot alkaloid. And if it is still not responding, then uterine balloon tamponade can be tried. Even if it is not effective, then we can go for surgical stepwise hemostatic suturing of the uterus, like B-Lynch sutures and all, before proceeding to hysterectomy. If the patient is very serious, we can ask for hysterectomy also to save the life of the mother. And second cause is the tears or trauma. So simultaneously, if we feel the uterus is contracted, still there is a massive bleeding, we should examine the patient under anesthesia or under in the labor room, right from the vagina, cervix, any perineal tear, cervical tear, uterine rupture. And if it is there, then immediately it should be repaired. And we can do it by, if it is during cesarean section, we can take out the uterus, exteriorize the uterus, and look for any site of bleeding. Maybe corners may be bleeding. Sometimes if during cesarean section, we can see some ovarian vessel, splenic vessel may rupture, subcapsular hematoma in the liver, may be there. So rapid management is very necessary. Repair the identified genital tract trauma, like cervical tear is there, repair it fast. Otherwise, you cannot save the patient. Sometime we may need to do pelvic arterial embolization if hematoma is in the broad ligament, and it is a very typical procedure and but life saving. And third is the retained. If there is a retained placenta or retained blood clots is there, do ultrasound examination and examination under anesthesia and manually remove the placenta as much as possible. And then we should give the uterotonics simultaneously or along with that. And even all the things are normal, still patient is bleeding. There may be coagulopathy. Continuous bleeding in contracted uterus, look for coagulopathy, full blood count, coagulation profile, urea electrolyte, and we should give immediate medical management. We replace the blood, coagulation factors, or fresh frozen plasma can be given. Surgery should not be undertaken in cases of coagulopathy until unless there is some other cause also, like atonic PPH or traumatic PPH. Only then surgery should be preferred. Otherwise, medical management is the best. So, attempt next slide. Yeah, next. So, use of uterotonic. Uterotonic, the agents are, we have mainly oxytocin, carbetocin, ergometrin, symptometrin, and misoprostol. So timing according to the doctor, it may differ. Somebody likes to give at the crowning of the head or delivery of the anterior shoulder at the second stage of labor or after the delivery of placenta. But sometimes it becomes late. So we usually prefer to give at the delivery of anterior shoulder. And cesarean section after the removal of baby, we give the uterotonics. It can be used for prophylaxis. Always use prophylaxis, carbetocin or centocinone. Active management of third stage is very important, and giving uterotonics is a part of active management of third stage of labor. And if there is PPH, we have to manage aggressively. Next. So carbetocin is not a new drug. I think it is a modified or one generation next version of the oxytocin. So, what are the drawbacks of oxytocin that is removed in the carbetocin? It is a next generation drug. So, carbetocin is heat stable, while oxytocin is very sensitive to temperature. It has to be kept on 2 to 8 degrees centigrade. So, just to maintain its efficacy. But in India, temperature is very high. Sometimes it is running up to 50 or 40. So, this drug loses its efficacy. And secondly, the half-life of the oxytocin is only 10 to 15 minutes, while in carbetocin, it is around 40 minutes. So these two drawbacks of the oxytocin is very well managed by carbetocin. And we give 100 microgram of carbetocin IV in 1 minute, or we can give it intramuscular also. Next. So there are so many trials have undertaken for carbetocin efficacy. And one is the important trial is the WHO champion trial. And this is a very large randomized double-blind trial. And in this, it is uh, run in so many countries simultaneously. 30,000 women across 10 countries were studied, including India. In India, we have taken 7,000 women from different institutions. So in this, carbetocin is compared and it is heat stable to the oxytocin to prevent PPH after vaginal delivery. So primary, the proportion of the women with blood loss at least 500 ml or the use of additional uterotonics, and the proportion of the women with the loss at least 1000 ml. And this study also give the result non-inferiority of the carbetocin over the oxytocin. So when the results of this champions trial shows, so efficacy of carbetocin is 14.5%, while oxytocin is 14.4. It is non-inferior to oxytocin, slightly better than oxytocin. And blood loss more than 1000 ml, 1.5%, it is 1.45%. And safety profile, unanticipated adverse effects, it is 4.9%, and in oxytocin is 4.7%. So the frequency of blood loss at least 500 ml, use of additional uterotonic with carbetocin was proven to be non-inferior versus oxytocin. So this trial also shows equal efficacy of carbetocin with compared to the oxytocin. Next. Again, Crokin review suggested carbetocin for preventing PPH, and this data from 11 studies involving 2,635 women were included, and the women undergone cesarean section. Carbetocin resulted in the statistically significant reduction in the need for therapeutic uterotonic compared to the oxytocin. Also, the carbetocin is associated with less blood loss compared to symptomatrin in prevention of PPH for the women who have vaginal deliveries and associated with significantly fewer side effects. Next, and guidelines and recommendations. So, in so many countries, WHO studies in 2018 only the following guidelines for PPH prophylaxis. So, carbetocin is also added in the this basket in 2018. And SOGC Canada also included carbetocin 100 microgram IV bolus. New Zealand Society also included this. FIGO included carbetocin, one of the recommendation for PPH management. Germany, Austria, Swiss, carbetocin is the first line for prophylaxis. 100 microgram IV slowly. FCOG France, carbetocin for non-inferiority of the oxytocin achieved by Champions trial. Next. So my experience with carbetocin, I am using is for last one and a half year, and I am using at a primary drug. And this is my first. I am sharing my 2 or 3 cases, important cases in which I am suspecting PPH. So this is a 32-year-old female, gravida 2, para 1, and live birth 1. Previous normal vaginal delivery. Now she's 39 weeks gestation with labor pains for past 6 hours. Uterus was overdistended and fetal heart rate is 156 per minute. Cephalic presentation, contraction were there 3 per 10 minutes. Cervix is 50% effaced, 3-finger dilated. Presenting part was at -1 station. After augmentation for 8 hours, she delivered a female child of 3.9 kg with cord around the neck. In this case, I preferred giving carbetocin, and uterus was well contracted and there was no PPH. So, why this case is important? Firstly, she is a 32-year-old lady with a large baby, relatively large baby, 3.9 kg, over distended uterus was there. And secondly, it is a prolonged labor. After 3-finger dilation, she took another 8 hours. So, and cord around the neck may be one cause of this or large size baby. So in this case, successfully carbetocin managed well and there was no PPH. Second case. Again, second case was my cesarean section. She is a 30-year female, gravida 2, para 1, and previous cesarean section. Now she's twin gestation with PIH. With 36 weeks of gestation, came with the labor pains since few hours. Her general condition on examination, there was no pallor, pedal edema was there, and blood pressure is too high, 200 by 110 millimeter of mercury. So she is a case of, she is a high risk pregnancy with PIH, with twin pregnancy, with previous seizure. On examination, uterus was overdistended, cephalic transverse lie for the first fetus, and there was a contractions are coming, and fetal heart was 145 and 165 respectively, and scar tenderness was present. So I took her immediately for C-section. She delivered 2.2 kg male child first and another 1.9 kg. And again, I have given carbetocin. I am in this case, and uterus retracted well, and there was no PPH. Again, she is a very high risk because of twin pregnancy and PIH and over distended uterus. And this is also very well contracted with carbetocin. No other uterotonic was given by me, and I'm well satisfied with the result of this drug in this case. My third case is very important. She is a high risk pregnancy. She's 37 year female, again elderly primary, and she's gravida 6 and 4 abortion, one live birth, previous LSCS, and she's diabetic, well controlled on drug, and 39-week gestation with polyhydramnios, and she was admitted for elective C-section, and she delivered a male child of 4.2 kg with Apgar 8 by 9. In the view of her elderly age, grand multipara, and big size baby, I have given again carbetocin, and it gave immediate effect, and uterus was well contracted, and there was no PPH. So all the three cases was very relevant. They are high risk for PPH, and it is saved by this drug. Thank you. Next.
Thanks, madam. Thank you so much. Thanks for your
Okay.
insights. We will go to the panel question. Madam, your experience of you have been using for 1.5, 2 years. You generally use as a first line or as a reserve drug?
Initially, I have started as a second line, but now I am switching as a first line.
Correct. With
Yeah.
experience and found safety.
Yes,
And
yes. But I am finding it very, very effective
correct,
and
correct,
useful.
correct, correct.
Yeah. And
Agar,
prostadine is very, so
yeah,
many side effects are there in when
yes,
I was
yes.
using prostadine, carboprost.
अगर effective है तो why wait for a result? We use it first
Yeah.
line. That's yeah.
Yes,
And you
yes.
generally use IV, madam, or IM?
Most of the time, I try to give IV, but in normal delivery, sometimes I give IM
Yes,
also.
yes, yes,
Yeah.
yes. Now coming to this, which although you can expect PPH in every patient, but there must be specific patients who are more prone or more likely to get PPH.
Yes, yes, we can assume in so many patients that this patient may land up in PPH, like over distended uterus is one of the
Okay,
foremost cause. So
okay.
twin pregnancy, polyhydramnios, large size baby,
Yes,
and grand multipara are the main cause of PPH. If there are a trauma also, matlab traumatic delivery,
yes,
then
yes.
we will look for PPH, and sometime coagulopathies and
Even
all.
even even fibroids can predispose them to
Yes, yes, adenomyosis is
yes.
very important. You will not
Uterus,
find out
yes.
adenomyosis on
Correct,
ultrasonography
correct.
if baby is there, but it may be a cause of PPH.
Absolutely.
Yeah.
So better not wait for any this thing. Start using the best, right?
Yes,
Okay.
yes.
When would you specifically prefer carbetocin over oxytocin? Because oxytocin is still in many places the drug used. Any specific area where carbetocin should be preferred over oxytocin?
Usually, though, I'm giving as a first
First
line, but
line.
some high risk patients are there, or
Yes, yes.
sometimes I don't want to give infusion if the patient
Correct,
is a
correct, correct.
cardiac patient or something like that. We cannot provide more fluid. In
Yes.
severely anemic patients, even where
Yeah,
fluid
high risk,
restriction is
yes,
there,
yes, yes.
yeah, high risk cases
High risk
where
patient
fluid
straight
restriction is,
away. Correct.
yeah, yeah.
Can we use carbetocin in case of a retained placenta?
Yes, in case we can use, but first we have to remove the placenta.
Remove the placenta, which is attached.
Yeah,
Yes.
look, examine under anesthesia, remove the
Yes.
placenta as much as possible. Only then we can give carbetocin. And somehow, if somebody is shifting the patient to the higher center in that period, I think we can give it.
And os should not be closed, importantly.
Pardon?
Os should not be closed. Os should remain open.
Yeah, or should not be
Yeah.
closed. Yeah.
Can we use carbetocin in Rh negative mothers?
No, yes, there's no
Yes.
harm in using RH negative
Rh
mother.
negative mothers getting a PPH will be a disaster because getting that blood will be difficult at that point of time, especially in the
Yes, yes,
periphery.
yes, yes, yes. So I think it should be used. Yeah.
Can a doctor use carbetocin for prevention of PPH if oxytocin is used for labor induction? I mean, many of them
Yes,
would be doing this, yes.
yes, we can use labor induction. Maybe we are giving very small amount of oxytocin. It will induce contraction, but not a sustained contraction. So we can use carbetocin after the induction is over.
Correct.
Yeah.
In which cases you would prefer IV? Now you use IM also. In which cases you would prefer IV or IM or specific place for IM in the therapy?
So IM, if we are giving carbetocin IM, I have seen it have more sustained effect up to 90 minutes or more. So
Okay.
in cases where we are suspecting PPH
Hmm.
or either there is atonic or large size uterus, I will prefer to give IM.
Madam, what is your opinion about prefilled syringe, which has to be only IV?
Prefilled syringe.
of carbetocin, which can be used only IV, not IM. You think they'll be
I
useful?
think it will be to my thing. I think it will be much better
Yes,
because
because you save
sometimes the
time in
staff
taking.
may take,
Yes,
yeah, it may take time to refill the syringe and all
yes,
these
yes.
things. So it will save the time.
And it,
It should be
and
given at a proper time. If we are
absolutely
giving after the removal of placenta, it will be not much more effective.
correct.
Yeah.
And sometimes when you remove blood, remove the solution, the whole solution may not come apart, maybe here
Yes.
and there.
Yes.
Yeah, exact
Yeah.
dose may
Yeah.
also.
Yeah. It may spill. It may.
Yes, yes, yes.
Yeah.
If a
Yeah.
patient is not responding adequately to carbetocin, additional uterotonics that you would use.
Yes, it is not the question of using one drug or two drug. It is
I
the
know.
question of using saving the life of the women.
We will
So
use
we can
all.
use anything. I will use to give prostadine also,
Correct,
and
correct.
misoprostol also, taxakind also, trenexakind also.
Yeah, yeah, yeah,
So
yeah.
yeah, yeah.
We would
Blood
use
is
all.
always a costlier thing, and to
Yeah.
save a life is very
Life,
important.
exactly, exactly.
Yes.
What are specific advantages of carbetocin over oxytocin, misoprostol, carboprost, and methyl ergometrin?
So, as far as oxytocin is considered, it is a better version of oxytocin. It is heat stable and it is prolonged acting. No infusion is required. As far as misoprostol comparing, misoprostol give lot of chills and rigor, fever may be there, vomiting is there, nausea is there, and carboprost is a havoc. Patient has lots of vomiting, diarrhea, and all thing.
And
And
asthmatics you
methyl,
cannot give it ultimately.
yeah, even during cesarean, patient start vomiting, and this is very
Probably. Dangerous.
typical
Yeah,
situation. Yeah, a methyl ergometrin is a good drug. It can be combined with this in the
no,
cases of that is placenta previa.
correct,
It methagen will contract the lower segment also.
correct, correct.
Yeah,
And madam, have
but
you seen
methagen again we cannot give in cases of high
hypertensive?
BP.
Yeah.
Yes,
Ma'am,
hypertensive patient.
have you seen those ADH related side effects with oxytocin? How commonly have you seen them?
Not much. Mine is a tertiary center, so
Okay,
we take a care in of these patient in ICUs,
I
and
understand. Yeah,
cardiologist is there,
yeah.
and
Then
all the team is there. So we is very particular about the giving fluid.
chance is much less.
We
Yes,
can give this oxytocin by the infusion pump also
correct.
when we are not giving so much of fluid.
Should carbetocin be kept as a reserve drug? I mean, you already answered this. You're using it as first line.
No, no. Why to reserve it when it
Exactly.
is a better option?
Exactly. Yeah.
Yes, and it's not so costly as it
No, no,
appears.
no. And
Yeah,
finally, life is at stake.
yeah,
Yeah,
yeah. Definitely.
exactly.
Yeah.
How do you compare adverse effect profile carbetocin over oxytocin? Have you seen any side effect with carbetocin now that you use over 1.5, 2 years?
Yeah, I have not seen. Sometimes I have to give additional utotonic.
That
Otherwise, I
is,
have don't
yes,
seen anything.
side effect
Uh,
wise.
no, no,
No,
never, not yet.
good,
Yes,
God bless. And your
thank
one
you.
line to conclude about carbetocin.
Efficacy, tolerability.
Yeah, generally your
Yes,
take.
yes. Any obstetrician always want her patient to be healthy and happy, and
Absolutely,
there should be no
absolutely.
PPH.
Especially
And
in the golden
somebody and
moments.
somehow any drug is helping, we are ready to adapt it.
Correct, 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 correct.
Yes.
Thank you so much, madam. Thank you.
Okay.
It was wonderful, your insights, especially the case studies and the insight that you
Yeah.
gave, you've been using for past 1.5 years, 2 years. I mean,
Yeah.
yeah, thank you so
Thank you
much.
so much. It
Yes,
was
thank you.
very nice interacting with
Yes, it was
you.
very nice, and it was, I mean, ultimately, doctors want your insights for all this. It is insights which help.
Yes, yes.
Yes.
Thank you.
Anyway, yeah. Thanks all the doctors who took time from their schedule and attended this webinar. Thank you, marketing team, for conceptualizing. Thank you, field personnel, for coordination. Last but not the least, thank you, IT team, for your support. Thank you, all of you. Signing off. Thanks, madam, once again. Thank
Thank
you.
you so much. Well, okay.
Thank you, ma'am.
Okay.
मैं तो मला पण तेच बोललेला की
Thanks, Girdhar.
Yes,
Thank you,
I
doctor.
was
Thank
not
you.
able